going to talk to us about the weaning from temporary mechanical support and the role of inotropes in this scenario. Prego, Fabio.
Thank you. Thank you, boss. So I hope you still have some glucose in your blood to stand my last talk. I only have these disclosures related to this talk, so both the topics I'm going to talk about might be a potential conflict of interest. I hope they won't. And the second disclosure is that I will talk about pathophysiology. If you run a PubMed search with ECMO and inotropes or ECMO and levosimendan, you will have about, after filtering the non-significant papers, you will end up with 5 or 6 papers. If you ran this search 1 year ago, there would have been 3 papers on ECMO and levosimendan, so absolutely no evidence, if you mean by evidence RCTs. So this is the agenda of my talk. Why does a patient need cardiac support? How do we assess and what is weanability, and how we can practically wean the patient? Of course, for any cardiac support, be it a drug or a mechanical support, our first target is to obtain an adequate peripheral perfusion in order to minimize oxygen debt. And we know that in most critically ill patients, we have a variable degree of oxygen supply dependency due to the conditions that patients present. Moreover, Dr. Boucher, they warned me that this monitor is lower than yours, but I didn't pay attention. So Dr. Boucher already showed us, so it is my work. I don't have to speak anymore about VA coupling. If you see VA coupling as the relationship between afterload and LV performance, we know that the optimal ratio is around 0.8. It means that the left ventricle has an elastance which is slightly superior than the arterial elastance. And we know that in cardiac insufficiency and cardiogenic shock, this relationship is impaired and the ratio is raised. I mean, arterial elastance increases and ventricular elastance decreases. So the relationship, the result is increased. We have to keep in mind this relationship because our first aim when we put a patient on ECMO should be that his native heart recovers enough for us to be able to separate him from ECMO. So this leads to a double aim of our cardiac support. The first is the immediate support of circulation by restoring peripheral perfusion, adequate perfusion. But the second and equally important target is to support the failing heart. So we should aim at increasing coronary perfusion, decreasing myocardial oxygen consumption, and decreasing the work of the left ventricle, which is failing. Unfortunately, we have come to a point that the native heart of our patient is not able to cope with the working load, so we decide to put him on ECMO, and so we are adding to an impaired VA coupling another source of impairment, because VA ECMO is good for the circulation, but it's not so good for the LV because it increases afterload. It might increase the distension of the LV, and so it's not very friendly to the LV. So we have to put in place a number of tricks, of measures, in order to keep the LV and the heart globally in good conditions while the patient is on ECMO. So all this part was meant to lead you to the point that if we want to ask ourselves if the patient is weanable, we have to start from the beginning, from the first time we see the patient in the emergency department, in the cardiology unit, wherever, and we are deciding whether to put him on ECMO or not. This is where we should start thinking about when and how we will be able to wean this patient. In other words, and starts from the beginning. So, of course, weanability of the patient is due to a number of reasons that are existing when we put the patient on ECMO. It depends on how we treat the patient during support. Of course, it depends on how good we were and how severe the condition, the initial condition was in order to allow for recovery of the heart. And lastly, it depends on how we decide to wean the patient. I'm sorry, I still forgot that you are quicker than me to see things. So regarding baseline conditions, the two topics that I'd like to stress is that we should ideally have correct indications. This is easier when the patient is unstable, but not so unstable as in peri-arrest or cardiac arrest, when the patient is in cardiogenic shock, but we have a few minutes or a few hours to decide. But when we have to rush, it's not so easy to be precise on the indication. And of course, we should decide which is the best moment to start support. During ECMO, the two main organs that we should care about are the heart and the lungs. I'm trying to underline both things. I mean, not only the heart, but the lungs, because as most of you know, lung failure during VA ECMO was one of the reasons for failing a weaning trial. And of course, we have to plan. We should have a protocol. However, in the single patient, as no patient is the same, we have to plan a weaning strategy. So how do we assess weanability? First of all, as you will see in all published protocols, we have to be reasonably sure that the precipitating condition that led the patient to ECMO has been managed, has been solved, or at least is stable. Then we have, of course, if a patient has 5% ejection fraction, the left ventricle is completely akinetic, we start with a pre-test probability, which is extremely low for us to wean the patient. If this is not the case, we have to perform a weaning trial based on hemodynamics, echo, and indexes of tissue perfusion, and see if the patient is stable during this weaning trial. Stable in this case means that, of course, we are reducing the blood flow, the support from the pump, and simultaneously, the patient's native heart must be able to cope with that and to improve its native function. Something that is not so irrelevant is what are our endpoints in assessing weanability. I won't go into much detail, but remember that a weaned patient doesn't mean an alive patient, a patient who's walking home and going back to work or whatever. So if we only stick to weaning, this is not the same as saying patients survived, patients returning home. So first of all, we have to measure. What do we have to measure? What we do in our institution, the chairman's and mine, is that we combine, and this is the case for most institutions that I'm aware of, we combine conventional hemodynamic monitoring and echocardiography, be it surface or transesophageal echocardiography, in order to evaluate all the components of hemodynamics, pressures, volumes and areas, and not secondarily oxygen dynamics. So this is one of the first protocols published by the Pitié-Salpêtrière group in Paris, and it summarizes what I've just said. So first of all, we have, and this relates to the initial indication, first we have we must have a condition that is compatible with recovery of the heart. Then the patient must be stable. Pulmonary function must be adequate. Otherwise, we can consider switching to VV ECMO if this is not the case. And then, at this point, we can perform a full weaning trial and see if the patient copes with it or not. It's written, it's not so big to read, but I will guide you through it. These are the indexes that the French group proposes as indexes of weanability, as these were the only indexes that were significantly linked to the success of weaning trial. And they are sufficient, you see, it's not so high, but at least 20–25% LV ejection fraction. An aortic VTI, which is the ejection of the aortic with the LVOT measured with tissue Doppler, and a systolic, with Doppler, and a systolic wave of tissue Doppler at least of 6 centimeters per second. Interestingly, as who does ECMO knows, one of the causes of failure is RV failure. There is no index of RV function in these points, but this, as I said before, is just because on multivariate analysis, these were the only indexes linked to weaning. So we've said that we want to liberate the patient from ECMO, and this means that once we have wean the patient of ECMO, his organs, his peripheral tissues must be well perfused. However, I hope I also convinced you that another important point is that once we have separated the patient from ECMO, his heart must not decompensate again. And this means that in the VO2-DO2 balance, we should also pay attention not to increase, too quick, not to increase too much the myocardial oxygen consumption. I had the same one as Dr. Boucher, and I changed it. So I put the PTA weaning protocol on this slide just because, as compared to ours or the Papworth one, it is the only one that, even if we do the same, that writes down black on white that before attempting a weaning trial, you should have the patient stable without or with low dose vasoactive medications. So, not all the patients, in my experience, a minority of the patients will succeed a weaning trial with absolutely no medications. They are still recovering from their heart failure. They are not so stable. They might be stable enough to be separated from ECMO, but may be not stable enough to walk on their own feet. So, on one side, we have vasopressors. Of course, we might need vasopressors if the mean arterial pressure is not high enough to ensure adequate organ and coronary perfusion, but we know that this will compromise, in a way, our VA coupling. And on the other side, we have inotropes and inodilators, which of course increase contractility, but at the expense of increasing VO2 consumption of the myocardium. In the case of inodilators, we have an additional positive effect of reducing arterial elastance. And then we have a third way, I think you suspected it, that is the one of the calcium sensitizers. We have an increased contractility. We have, I can see the pointer, I hope you do. We have a reduced, as for the PD inhibitors, arterial elastance, but the difference is that we don't do it at the expense of an increased oxygen consumption. So, we have still a few minutes, so I will guide you through a number of short clinical scenarios. The first one is a 67-year-old man with a large myocardial infarction, which was complicated by cardiac arrest. He underwent ECPR in the emergency department, received 3 drug-eluting stents, and now we are 4 days after the initial event. The patient is on ECMO with a, with 4 liters per minute of blood flow, a, let's say, not so high dose of inotropes, 4.4 dobutamine, and the native heart of the patient is ejecting almost 2 liters per minute. So for those who are not so familiar with VA ECMO, let us consider that this patient has roughly 6 liters per minute of peripheral perfusion. Do you think that this is, with these numbers, with these hemodynamics, would you like to try, after 4 days on ECMO, would you like to try a weaning trial? Who would like to do it? Only one hand? No, a few hands, okay? What if I add the echo? Okay. Those who are more experienced will recognize that it's not likely that if the patient was not a chronic heart failure patient, I must have been very, very bad at curing him if in 4 days I made such a ventricle. But so the first point is that echo must always guide our weaning trials, and the role of levosimendan in systolic function is well recognized. And remember that systolic dysfunction is the single main factor influencing weaning. Another patient, still a man, younger, 56 years old. Another, same story as above, myocardial infarction, cardiac arrest, ECPR. This patient had a longer course on ECMO, 2 weeks. The RV was not so bad, but the LV did not improve enough to be separated from ECMO. So he was switched to a paracorporeal VAD, and after 2 days on the LVAD, he started to deteriorate, and he showed some echographic features of RV dysfunction. You can see that the free wall of the RV is not contracting, same in the short axis view. So the second point that we have to keep in mind while weaning a patient is that the RV is as important as the LV to predict weanability and survival. And we have, not so strong, but we have a certain evidence that levosimendan also works on RV contractility. Third case and third point, a lady at last, 72-year-old lady. She was a post-cardiotomic ECMO, 6 days on ECMO, 3.4 blood flow, 5 mics of dobutamine, and 2.4 native cardiac output. She was a 55 kilograms lady. So it's about, again, 6 liters per minute of total cardiac output. We performed conventional hemodynamics that were satisfactory, 70 millimeters of mercury of mean arterial pressure, 19 millimeters of mercury of mean pulmonary arterial pressure, a low wedge pressure. Echo, LV ejection fraction was adequate, 32%, with 18 centimeters of TAPSE, and no relevant issues on the valve side. So she was weaned off ECMO, but this patient already had an intra-aortic balloon in place when we put her on ECMO, so it was the first trial to wean her off CPB. Then we put ECMO and we left the intra-aortic balloon in place. We were not able, she had recurrent pulmonary edemas when we tried to wean off the intra-aortic balloon. And what we saw was that immediately after surgery and after being decannulated, she revealed an impaired diastolic function that was a little bit improved, but not so much after ECMO deconnection, and that was then improved after the administration of levosimendan that in the end allowed us to take off the intra-aortic balloon. So we've talked about systolic function, but we also have to keep in mind diastolic function. And we have, again, not an overwhelming evidence, but we have an evidence that, especially as compared to other inotropic agents, and namely adrenaline or dopamine, levosimendan does not impair and may help recovery of diastolic function. And the last point is that even if to a lesser degree than CPB, conventional CPB for cardiac surgery, ECMO causes a loss of pulsatility, and this in turn activates inflammation and worsens a pre-existing endothelial dysfunction. And we have seen there are few papers, I can say that because one of these was published by ourselves, quite low quality evidence, but that levosimendan improves endothelial function and improves inflammatory function. So, adding the last point, we have an influence of inflammation and endothelial dysfunction on, on vasodilation, on weaning failure, and levosimendan may help us in this point. So, what is our institutional protocol for weaning ECMO patients? Of course, it is always echo-guided. We do not perform a weaning attempt before the resolution of the acute process. We assess adequate anticoagulation and then reduce the pump flow down to 1 liter per minute or even less. Of course, we have continuous monitor of both conventional hemodynamics, blood gas analysis for lactates, and echo throughout the protocol. If the patient remains stable, his native cardiac output increases during the reduction of the pump blood flow, we can restore and resume full support in order to stop anticoagulation. This is an institutional protocol due to the fact that we mostly decannulate patients percutaneously, and so we have to have a coagulated patient when we do that. And then we can go to decannulation and separation from ECMO. If this is not the case, if at any point of the process, be it at the baseline or during the weaning trial, we have any condition, be it echo or hemodynamic condition, or a rising in blood lactates or clinical worsening of the patient, we resume full support, we start levosimendan without a bolus, and we reassess weanability not before than 24 hours. So in the end, I won't run through all the animations because I've already presented, but the only thing that the main reasons why I believe that levosimendan has a role in these patients is that we are not worsening myocardial function, we are not increasing oxygen consumption, and we are able to have favorable effects without some additional collateral effects. So in the end, my last slide, apart from what you use, no patient is alike, so measure, we can't control, we can't guide what we are not measuring, and this is the last point, and I've already presented it on the rationale, in my opinion, and with a small evidence from literature for the rationale for levosimendan. Thank you.